This is Shahzad Ahmed presenting the fourth video in the series of ECG lectures. In this video, we will discuss about the ST segment deviation, abnormalities of T wave, the QT interval as well as the corrected QT interval, the U waves, J waves, and the effect of various electrolytes on these entities. The ST segment is a very important part of each cardiac cycle ECG tracing, and its importance lies that it helps in the evaluation of ischemia. If there is ST elevation and its convexity is upward, as well as the scenario is suggestive of acute ischemic event, then it indicates acute ST segment elevation myocardial infarction. And for the diagnosis of ST elevation myocardial infarction, it requires ST elevation in at least two contiguous leads of a lead group. For example, if present in the inferior lead group or in the anterior lead group or in the lateral lead group, at least two leads are required for the diagnosis of MI. And at least 1 mm ST segment elevation at J point is required in all other leads except V2 and V3. Here it is important to mention that J point is the point where the QRS segment joins the ST segment. It is basically the junction of QRS with the ST segment. And the criteria for V2 and V3 varies according to age as well as the gender. In males less than 40 years of age, the ST segment elevation required in V2 and V3 is at least 2.5 mm, and in males more than 40 years of age, 2 mm of ST segment elevation in these two leads is sufficient to diagnose acute myocardial infarction, and in females this criteria is 1.5 mm elevation at J point in leads V2 and V3 for the diagnosis of acute ST segment elevation myocardial infarction. And ST segment depression, when present, it usually indicates ischemia. Here is shown an ECG depicting acute anterior and lateral wall myocardial infarction. You can see in leads V1, V2 and V3 ST segment elevation, as well as in lead 1 and lead AVL. Concomitantly, there is ST segment depression in inferior leads, lead 2, 3 and AVF, which is termed as reciprocal ST segment depression in this case. Important to mention is that ST segment elevation does not always necessarily indicate a myocardial infarction. There are some other scenarios in which there can be ST segment elevation, and the important are pericarditis as well as early repolarization. Both of these entities have ST segment elevation with its concavity upward. The difference is that in case of pericarditis, there is PR segment depression in all the leads which are showing ST segment elevation, and this case is reversed in lead AVR, in which there is PR segment elevation as well as ST segment depression. These are the findings for a patient with pericarditis. In contrast to that, in early repolarization, there is no PR segment depression. Another important difference is that ST segment elevation in pericarditis is usually seen in limb as well as precordial leads, whereas ST segment elevation in early repolarization is usually restricted to precordial leads. There is another important difference in these two entities, that the ratio of ST segment to T wave amplitude is more than 0.25 in case of pericarditis, whereas this ratio is less than 0.25 in case of early repolarization. This diagram has been made to make you understand the differences of ST segment elevation in case of pericarditis as well as early repolarization. We have shown the complexes from two patients, one with pericarditis and one with early repolarization. We have taken lead 1 as well as lead V6 as well as lead AVR. As already discussed, you can see that in case of pericarditis, there is a PR segment depression as well as ST segment elevation in lead 1 and lead V6, whereas the changes are reversed in lead AVR. Whereas in early repolarization, there is ST segment elevation in lead V6, no ST segment elevation in lead lead 1, as well as there are no particular changes in lead AVR. Another important scenario in which there can be ST segment elevation is a Brugada syndrome or a Brugada pattern ECG, in which Brugada syndrome has two types. Both have some degree of ST elevation, and the difference is in the morphology of ST segment. In type 1 there is curved ST segment elevation, and in type 2 there is saddleback shaped ST segment elevation, and these changes are usually seen in anterior precordial leads V1, V2 and V3. Coming to the T wave, it represents ventricular repolarization. Peaked T waves can be seen in the setting of hyperkalemia, and tall T waves can also be seen in the setting of acute ischemia. Here we have shown a complex with tall T wave representing hyperkalemia. QT interval is measured in the lead with the longest QT interval, and it is dependent on the heart rate such that it decreases with tachycardia. So, due to its variability with heart rate, a formula has been developed to determine the corrected QT interval according to heart rate, and this is called Bazet's formula, in which corrected QT interval is equal to the QT interval divided by the square root of RR interval. Lower limit of corrected QT interval is 390 milliseconds, and the upper limit for men is 450 milliseconds, and for women it is 460 milliseconds. Hypercalcemia usually causes shortened QT interval, and hypocalcemia usually leads to prolongation of QT interval. Some extra waves can also be visualized on ECG, and the most important is U wave. It appears after the T wave, and it is usually apparent at slow heart rates, and is usually less than one small box in amplitude, more prominent in leads V1 and V2, and it represents hypokalemia. Here we have shown a complex with somewhat flattened P wave, QRS complex, then ST segment, then T wave, and a small deflection after the T wave, which is termed as U wave. Another important wave, extra wave, which can be visualized in ECG is the J wave, which is a hump-shaped wave that appears at the end of QRS complex, and it has same polarity as the preceding QRS complex. It can be seen as a normal variant or in the setting of hypothermia, where it is termed as Osborn wave, or it can also be seen in Brugada pattern ECG, or it can also be seen in some patients with early repolarization pattern ECG. Here a complex has been shown which shows a small J wave just at the terminal portion of QRS complex and before the start of ST segment. Here we conclude the discussion on ST segment, QT interval, T wave and extra waves. Thank you very much.